Okay, thank you, Dr. Benjamin, for presenting me. First, I would like to thank the organizing committee for giving me this chance to present in this distinguished meeting. And my talk today will be about AML. This is a single center experience at the Princess Noor Oncology Center in King Abdulaziz Medical City in Jeddah. So in our study, we had a retrospective analysis of demographics, clinical characteristics, toxicities, and treatment outcome for adult patients with acute myeloid leukemia since 2000. Firstly, I will go shortly through some epidemiological data about acute myeloid leukemia. So there was around 60,000 new cases of leukemia in the United States in 2018, and that constituted around 3.4% of all cancers. Acute myeloid leukemia accounted for around 32% of all the new leukemia, with estimated death of 10,000 cases yearly. So AML is a disease of adults, so it accounts for around 80% of acute leukemia in adults, with some male predominance. And it was published in multiple studies that AML is a disease of elderly with a median age of 65 years at the time of the diagnosis, although we have some heterogeneous data as what was reported here locally in Saudi Arabia, and I will talk about that later in my presentation. So in Saudi Arabia and worldwide, there has been an evidence of increasing incidence of leukemia over the past 15 years, and that actually had a huge impact on the general population health as well as the health institutions. So next, I will present a few data from the Saudi Cancer Registry in 2016, and as we can see here, that leukemia ranked the 5th among the most common cancers in Saudi Arabia, while it was the 4th among male and the 6th among females. Looking here into the chart, which is comparing the age standardized rate for leukemia among Saudis and other nationals, as you can see here that the rate of the leukemia was 3.6 per 100,000 among male, and it was 3 per 100,000 among females. Coming here to the adult group, so we can see here that leukemia occupied the 9th among the most common cancers. And if we looked into the most common leukemia in Saudi nationals, acute myeloid leukemia ranked the 2nd one. And here we are talking about both pediatric and adult groups. This symbol curve is showing us the increasing incidence of leukemia as overall with age advancing. But if we are talking about acute myeloid leukemia, the median age at diagnosis among adults in Saudi Arabia was lower than other Western countries, and that has been demonstrated in different studies local in Saudi Arabia. So our colleague in National Guard Hospital in Riyadh, they showed that the median age at diagnosis was around 52 years. And we had also another study from King Abdullah Medical City in Mecca, where the median age of diagnosis was around 42 years. We have actually a similar data in our study. So as we know that there are many factors contribute to the AML treatment outcome. We know that elderly AML population, they do actually poor in general. And that has been attributed actually to multiple factors, including the poor performance status, the presence of multiple comorbidities, and the accumulation of different genetic mutations. These results actually has been revealed in multiple studies, either internationally or locally. So as we can see here, this is a paper which was published in British Journal of Hematology about the outcome of acute myeloid leukemia in England over 3 decades. And we can see here clearly that there has been an improvement in the outcome of AML among the young and middle age group, while the elderly population continued to have a poor outcome. We had also a similar data locally here in Saudi Arabia by our colleagues in National Guard Hospital in Riyadh, and we can see here the differences in the outcome among different age groups. Again, The impact of age on the AML outcome has been demonstrated across different ELN risk stratifications. The second most powerful tool in the prognosis of acute myeloid leukemia is the cytogenetics and molecular features, and everyone actually is familiar with this table, which is the 2017 ELN classification that has been established after analyzing the impact of different cytogenetic and molecular mutations on the outcome of acute myeloid leukemia. As we can see here clearly, the outcome among different risk groups. Also, we have some similar result locally in Saudi Arabia by Dr. Amal Abdul Wahab and her colleagues in King Abdullah Medical City, and the result it's comparable to the international one. Next, I will come into our study. So in our study, we present analysis for retrospective data of 190 patients with a non-ABL acute myeloid leukemia who were diagnosed or referred to Princess Neuro-Oncology Center between 2000 and 2020. Here we can see we had a total number of 190 patients. 22% of our patients were eliminated from the analysis because they underwent a palliative treatment, so we ended up analyzing around 149 patients. So if we come next to the patient or the clinical characteristics of our patient, we can see here that females constituted around 52% of our cohort, and the male constituted 48%. Coming to the age group, we can see clearly here that most of our patients were at young and middle age group between 14 and 60 years, while only we had 9% of our patients with the age group above 60. That actually gave us a median age of 45 at the time of diagnosis of acute myeloid leukemia, and that actually concurred with the other local studies. So this age group had reflected also the number of the comorbidities. So as we can see here, we have around 97% of our patients, they had no or one comorbidity, while only 3% with 2 or more comorbidities. So this is the white blood count at diagnosis, and we can see here that most of our patients were presented with a leukocyte count of less than 50,000. And the others are distributed in the chart. So looking into the cytogenetics distribution in our cohort, we can see here that we had 40% of our patients who were presented with normal cytogenetics. In version 16, we had 8%, and we had 10% of our cohort with translocation 8 and 21. And also we had 6% with trisomy 8. And with regard complex cytogenetics, including monosomy 7, the percentage was around 16%. It's worth actually to mention here that internationally, the reported prevalence of complex cytogenetics in AML patient is around 10 to 12%. So we concluded actually that we might have a trend toward a higher prevalence of complex cytogenetics among our population. Next, we looked into the distribution of the patient as per the 2017 ELN risk stratification, and we can see here clearly that we had 31% of our patients who fell under the favorable risk group, while we have 27% under intermediate risk group and 35% in the adverse risk group. Coming now to the result. So firstly, we looked into the end of induction outcome. So we saw that, we observed that complete remission, CR or CRI, has been achieved in around 69% of our patients, while 25% of our patients were refractory, and we had 6% death in induction. And when we looked into the impact of the ALN risk stratification on the outcome after the induction, it showed the superiority of the favorable risk groups over the other groups. So the CR rate among favorable risk groups was around 95%, while among intermediate risk group, it was 67%. And those patients in the adverse risk group, they had the worst end of induction outcome with 49% only. Now we will look into the overall survival and the leukemia-free survival. So in the whole cohort, the overall survival was 20 months, while our leukemia-free survival, the median leukemia-free survival was 13 months. Then we went through a subgroup analysis. So considering the age group, it's clearly seen here the differences between the outcome in the overall survival among different age groups, and that was statistically significant. Again, the outcome in the leukemia-free survival was statistically significant among different age groups. Next, we looked into the result as per the ALN risk stratification, and we can see clearly here the differences between the differences in the outcome between different risk stratification groups. So the median overall survival among favorable was not reached, and we had a mean overall survival of 132 months. While those patients with intermediate risk group, we had a median overall survival of 22 months, and the worst was among patients with adverse risk group with only 10 months. The same thing was demonstrated with regard to leukemia-free survival. So the median leukemia-free survival among favorable risk group was not reached, and the mean duration was 134 months, while the median leukemia-free survival for the intermediate risk group was 14 months, and for the adverse it was 8 months. And that was statistically significant. Then we looked into the result of based on the different cytogenetics at diagnosis. And as you can see here that the best result was with population with inversion 16. So the median overall survival was not reached, and they have a mean of 157 months as a mean overall survival. While those patients with the normal cytogenetics, they had a median overall survival of 54 months. And surprisingly, we found that patients with translocation A21, they did poor in our study with a median overall survival of 20 months. And the worst outcome, as usual, was with people with the complex cytogenetics with a median overall survival of 5 months. The same thing was revealed in the leukemia-free survival. So the best result was with the inversion 16 with mean leukemia-free survival of 155 months, while patients with normal cytogenetics, they had a median of leukemia-free survival of 47 months. And again, translocation A21, they had a poor outcome with regard to leukemia-free survival with a median of 13 months. Coming to the impact of white blood count on the outcome, so we can see clearly here that there has been no difference in the outcome, either in the overall or leukemia-free survival, based on the leukocyte count among our cohort. And I think that that was due to easy accessibility to some facilities like leuko reduction in our institution. Also, the early initiation of the chemotherapy contributed to a similar result. Again, we looked into the patient with either presence of or absence of extramedullary disease. And again, we found that there has been no difference in the outcome among those two populations. Finally, as we saw that most of our data actually are comparable to the internationally mentioned data with regard to the outcome of acute myeloid leukemia, considering the age and the cytogenetic and the ELN risk stratification. But the only discrepancy we found is among patients with a translocation with 821. So I've just mentioned here a few more data about our patient with the translocation 821. So we had a 14 patient in this subgroup who were treated in our center. Complete remission was achieved in all of them. Relapse rate we have among those patients was 57%, and 37.5 among the relapsed patient, they were salvageable. One patient remained alive after salvage chemotherapy alone, while one had a non-relapsed death post-allogeneic stem cell transplant, and the third had died due to disease relapse. We had 5 patients who underwent allogeneic stem cell transplant. 4 of them were in CR1, and 1 of them in CR2 only. So in conclusion, median age at diagnosis of AML in our center and concur with the other data which was mentioned in Saudi Arabia is lower than other countries. Also, we have seen that the age and the genetic mutations have the most impact on AML treatment outcome. I would say that there is some trend toward a higher prevalence of AML with complex cytogenetics in comparison to the reported data internationally. Acute myeloid leukemia is a heterogeneous disease, and that might cause a variability in the outcome among different population. And we have observed that in our patient with translocation 821, where they had an inferior outcome in comparison to their reported data in other studies. Also, incorporations of newer medications has led to a better outcome in different studies, and we'll be awaiting for our local data in Saudi Arabia. By that slide, I conclude my talk. Thank you very much, and I'll be happy answering your questions.